We work on improving outcomes of extremity injuries, open fractures, penetrating muscle injury, ischemia reperfusion injuries. So I actually arrived here about 12, 13 years ago, and I've seen a big change. A lot of it has to do with the funding. During the war, large amounts of funding came to actually translate basic science discoveries into clinical practice. And so about in 05, 06, funding started coming through Congress, and then an increase of our internal funds, which allowed us to really nail down on a lot of the big questions. The other thing that's really come in is tissue engineering and regenerative medicine. So a lot of things in the early 90s, the term tissue engineering was coined. And what this is developing scaffolds and cells and delivering growth factors to promote healing. And during that time, during the first decade or so, it was kind of in its infancy and not a lot of probably not a lot of concrete results we're having. And then recently, things are picking up and things are starting to get transitioned into the clinical practice. We're not in clinical practice, but at least in clinical trials. So I think another decade or so from now, the work from the last several decades will actually be realized in patient care. So for me, there's multiple aspects. So the prosthetic limbs are for people who've already had an amputation. And it could be primarily, actually at the injury site, or it could be later on because the limb couldn't be salvaged, or the salvaged attempt did not work out. And that's roughly 5 to 15% of the amputees is because the salvage did not actually, wasn't optimal performance, and there's sometimes a lot of pain or they get infected. And so what we're trying to do is focus on the limb salvage. So for every amputee you see, there's multiple limb salvage patients. And if you look at the results both in the civilian world and in the amputee, in the military data, amputees, comparing amputees and limb salvage, most studies will say that their outcomes were about the same, which is very poor. You see little anecdotal pieces of people running with a prosthetic, that one with a person running around the track with President Bush, George W. Really, I think, kind of set the field back, because what it's saying is saying, look, they're doing so great, and some are, but there's also tons of injury, tons of morbidities, skin breakdown, heterotopic ossification, infection, and then also during this time, the limb also starts to shrink. And so they're constantly having to go back in and resize the prosthetic to fit the residual limb. And so, and that's just with the amputees. On the limb salvage patients, there's even more issues. There's infection, there's bone non-union, and even if you get those to happen, you still have the scarring and tethering, which limits the range of motion of the limb. And then residual pain. Lots of issues are with the joint, so you have osteoarthritis. And then the other thing, which really has come out of this war, is focused on the muscle defects. 80% of all the injuries are penetrating injuries. And when you have penetrating injuries, you usually have missing tissue. And so if you can get the bone to regenerate, you might have union, but what you have is essentially a limb that's not functional. And so this missing muscle, we coined the term the volumetric muscle loss, which is just what it is, a missing volume muscle. And there's this limb no longer has the ability, or this muscle group, to extend or contract, flex the joint. And therefore the patient, or the wounded warrior, does not have optimal function. We've gone in over the last probably 7, 8 years and looked at why why people are actually choosing to have their salvaged limb removed. and it's usually pain and then not function, which goes around with this volumetric muscle.